one of the things that I know is such an interest of yours is acne and scarring. And, I think from my perspective, one of the things I think people underestimate, especially if they themselves haven't had acne, is the psychological impact that it has on people and how much, even years later, people are still quite sort of mentally scarred as well. They're very frightened of their acne coming back and how they felt about it. And although we use much lower doses of Roaccutane nowadays, people still seem to be quite scared of it. It seems to have had a reputation maybe 20 years ago of potentially impacting people's mental health. And I sometimes feel it's an unfair reputation that it seems to be struggling to shake off. I'd love you to speak to that a little bit.
Yeah, look, I wrote a little bit about this earlier on, probably 20 odd years ago. But realistically, acne is the most devastating disease of younger population, certainly as far as skin disease goes. It's got the highest rate of suicidal ideation, the highest rate of suicide of any dermatological disease. It is, without doubt, psychologically devastating. And the cruelty of acne is it comes at a time when people are forming their sense of self. So really, if people got acne when they were 40, they'd cope with it a lot better. But people get acne at exactly the wrong time when they're developing friendships, developing relationships, developing their sense of who they are, and it devastates that really. And the problem is that no offense, social media, Shauna, but I hate social media. I think it should be banned for over 16-year-olds as well as under 16-year-olds. But it really is at its worst at things like Roaccutane, where it just spreads dissemination like I won the election sort of thing. It's just, you kind of, it disseminates untruths. And yes, there is some mental health issues with Roaccutane, but the reason that no study has shown that Roaccutane has mental health issues on a population basis is because most people who go on Roaccutane are so joyous that they've lost their acne that it swamps the people that are getting depressed because of their Accutane. It does happen. I tell people up to 5% of patients will get mood depression. But I haven't seen it result in suicidal ideation like acne does, and acne scarring does. I've still got patients who are suicidal. I had a 15-year-old that I don't know how I got him through his acne because he was impervious to acne. It didn't work for him. And I couldn't actually keep him on it because of the mental health issues that he had. But we got him through it. But I can tell you it was touch and go whether he's going to suicide. And I have had a patient or two suicide with their scarring. It's just devastating. And I think that parents have been put off having their children go on Roaccutane really unnecessarily and purely because they hear from a well-meaning something or other that it's going to, bump their child off because of depression. When most times, probably 90%, the mood actually goes the other way because of the effect that it has on the acne and therefore the self-esteem.
I agree 100%. I think that the person's probably more at risk of their mood and depression with untreated acne than they are the other way, 100-fold.
Yeah.
And in terms of acne scarring, what are you doing right now? I mean, I know that you're someone who has an arsenal of weaponry that you use to treat these things, but what are your favourite things to use at the minute?
Some years ago, and probably one of my better papers, I'd have to say, is the grading scales we produced back in 2006, quantitative and qualitative grading scales, and that's based on burden of disease. So burden of disease means just that, how much it's going to impact the patient or likely to impact the patient. And so there are 4 scales for that, 4 grades. And it does depend which grade you're in as to what we do for the patient. And grade 1, for example, is what's called macular scarring, or is it's flat but it's discoloured, whether it's red or brown or even white. And we have treatments, obviously, for those, incorporating lasers and skincare and stuff that would impact on the colour rather than necessarily the scar. But once you start getting into 2, 3, and 4 disease, 2 is when you can see it with kind of tangential lighting, like in an elevator when the lights come from on top, or in a bathroom mirror when you've got a magnifying mirror especially, but not obvious at conversational distance. And grade 3 is conversational distance because you can stretch it out, and grade 4 is when you can't stretch it out. Normally, the burden of disease goes pretty much proportionally to those gradings. So for grade 2, for example, we used to have to take people to theatre and do a full face CO2 because there was nothing else to deliver to them. But nowadays, you can do through laser-assisted drug deliveries and fractional technologies, you can actually get away with grade 2 and O as just that minor scarring, just with things like needling, and we use a bit of insulin. Obviously, it's off-label for this sort of thing because insulin is a growth factor, and we found that pushing it through needling, radiofrequency, fractional cautery, or fractional lasers really does improve the quality and the rigor and the turgor of the skin, so that grade 2 scarring can be ameliorated with that. When you get to grade 3 scarring, I think you need something to fill the volume. In grade 4 is probably the same. Fill or decrease the volume depending on if it's subtrophic or atrophic. And for those ones, I think, I invented a technique called the stalagmite technique, or the tower technique for filling for acne scarring about 10 years ago. And we use that still. It's instantaneous gratification for patients, which is nice when it comes to acne scarring. And so we literally do a pillar of filler, literally in each scar. You raise the scar on a column of the filler, and it's pretty good. It works. A couple of treatments you need, and a month apart. And then you usually cement the improvement with something, whether it's a fractional device of some description, whatever your favorite is. And then you have the gross atrophy or the ice pick scars, in which case there are specialized treatments. So ice pick scars, you'll often use the cross technique, which is very strong acid down the holes to poison the inside of the scars. And with gross atrophy, you need filling or subcision, which is surgically undermining the scars. And for the deep, what's called boxcar scars, the deep scars, it does require L-Kligman's punch techniques, and they do very well. So you can actually literally core a scar out and throw it away and sew it together, or graft it, or you can actually just allow it to elevate without taking the punch out of the skin. So there's a lot of techniques. As you said, there's a potpourri of techniques, and there are plenty that I haven't mentioned, but certainly they're the go-to ones.
Do you find that your acne scarring patients are incredibly tolerant of sort of discomfort and downtime in terms of treatment because they're so motivated by getting rid of their scarring?
Yeah, pretty much. Yeah, it's a different population to the rejuvenation patients. Yeah, they've got a disease and they're medical in my eyes. So, it's you're doing something for them. They appreciate you trying. They realize there's no cure for an acne scar. I can't get rid of an acne scar. All I can do is make it better. And that's a bit of a downer, isn't it? That you can't get rid of the scar. But we just can't get rid of the scar. Yeah, but there's been a lot of discussion about fetal wound healing, which, as you know, doesn't produce new scarring. You can't scar as a fetus because you'd be distorting the infant all over the place as they grew. So there's got to be a scarless mechanism. Why it gets turned off? Go figure. There's no reason why it should be turned off in adulthood, but it is. And you can't seem to get it back. And people have been trying to echo fetal wound healing forever. They try to see if they get the magic holy grail to remove scars or prevent scars, but we can't seem to do that yet.
And what about the likes of the exosomes and things? Are you a fan of those?
I know yet. I think the jury's out, isn't it? I think turning on cellular activity has always been a bit of an interest, hasn't it? So whether it's the LEDs that everyone used to poo-hoo before they became fairly mainstream, to this now, to stem cell technologies, to all this sort of stuff that's turning on cellular metabolism. It's got traction. It's got traction, nutraceuticals traction as well, obviously, with the mitochondria, some of boosted preparations, nicotinamide and that sort of thing. I mean, there's no science at the moment, but it deserves a little bit of largesse to allow science to develop. I'm not a fan of PRP. I've said it in literature before, and I think it works for about 3 months, and that's about it. It does work for hair if you want to do it every 3 months, but you got to do it every 3 months. But some people do that quite happily. But for rejuvenation, is it enough? I'm not sure it's enough. But certainly that sort of technology moving in that direction, I can see that there's reason to go there. And so I would just give it a grace period of a few years to see if it develops. There's a lot of shonky sort of stuff coming in at the moment, with, and it'd be very difficult to study because every exosome company seems different, and what they're preparing, what they're doing, how they want you to use it, whether it's injectable or topical, or whether how many millions of things it's got in there, and so it's a wild, wild west at the moment.
And even if there's anything alive, as it were, whenever you get it. So, I think it's going to be a watch this space one. One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard, and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment, which is why I've created the Menopause Appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs, and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight, and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis, and leave you with a comprehensive, tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrshaunawatts.com.au. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.